and we start. Okay, well, welcome to the Essence of Medicine. Today, we are going to talk about the indication for transcam in OLLIF. And obviously, that is one of the methods we fuse the spine. This is a little more specific. Our usual format for our podcast is for layperson, people who are not doctors. But unfortunately, this is a more specific podcast. And I think the goal of this podcast is to identify in what situation the transcamin olive is an indication. This is more suitable for people who have been doing spine surgery already. Now, Dr. Farabakhsh, tell me about your current practice. Where are you? What do you do? Introduce yourself, please.
Hi, I'm Dr.
I'm
Farzin
sorry, I haven't
Farahbas. I'm a
trouble.
Please go ahead.
I'm a neurosurgeon from Iran, and my practice is mostly trauma surgery and many cases of spine surgeries here. Right now, we actually do open surgeries. Most of our spine surgeries are uh, open surgeries. We usually maybe some young patients go under microdiscectomy or open discectomies. Older patients with uh, stenosis or listhesis, we do open fusions and decompressions. That's
Yes.
how we do it here.
Okay. Well, and Dr. Gilmartin, you are our fellow in Inspired Spine. You are as well orthopedic surgeon. Please introduce yourself very shortly.
Well, I'm Nida Farwood-Gilmartin, and I recently graduated from my third spine fellowship, but there were combined neurosurgicals, orthopedic spine fellowship, and effectively, like you're saying, Dr. Farabakhsh, I was taught the classical spine surgery with open. I don't want to say maximal invasive because it's the only approach we know. And I have had approach to the bread and butter degenerative spine from a little bit deformity, not as
I think you're cutting off Dr. Gilmartin. So let's continue. Dr. Farhad, you are in Germany, but what kind of, generally, what kind of surgery, if you can participate, just tell us who you are and what kind of spinal fusion do you usually perform in Germany?
Hello, everyone. I am doing my neurosurgery residency, and I am only allowed to assist different kind of the degenerative changes, and it can be one or 2 point the disc prolapse and all this instrumentation. It's also minimal invasive procedures, and I am still now looking, reading and learning phase.
Okay, so let's, I see we have Dr. Atari here. Dr. Atari, if you can as well share your main form of spinal fusion that you are currently performing. We just want to go about what other methods out there, what is special about OLLIF, and what is OLLIF a good kind of surgery for, and what is not good kind of surgery for. If you can share, tell us where you are and what is your main method of fusion.
Assalamu alaikum. Hi, I am Dr. Natik from Pakistan. I am recently graduated new young neuroconsultant from Punjab Institute of Neurosciences, one of the biggest in the Asia for spine and neuro trauma and also elective surgeries. We are allowed to do and assist spine trauma surgeries and the elective surgeries where we do tumors.
Okay. Yeah, we are hearing you. I think it was some Please continue.
We basically in our center we are doing more tumors than fixations, but at every list we will do 2 to 3 endoscopic and minimal invasive spine surgeries and TP fixations.
So let's talk about the now. Let's obviously there is a method of treating the spine. It's called fusion, where we take the bad disc out, we put something inside of the disc base, and we stabilize the spine with screws above and below. And this slide is a very crude schematic of all the ways you can get to the spine. And today we are going to talk about the so-called oblique lateral posterior lumbar interbody fusion, but there are all the other methods of getting to the spine, including what we call posterior lumbar interbody fusion, transforaminal lumbar interbody fusion, anterior lumbar interbody fusion, oblique lateral interbody fusion anterior to psoas. This procedure is done with patient laying on their back, prone. I'm sorry, supine. This procedure and direct lateral interbody fusion is done with the patient on the side. All the other procedures are done with the patient laying on the belly. We call it prone. But let's talk about, to what I understand, Farzin, in Iran, mostly you perform PLIF and TLIF. Is that correct?
Yes, because we mostly do open surgeries. We don't actually do MIS surgeries for lumbar spine.
Okay.
Sometimes even some surgeons don't put interbody fusions when they fuse the spine. They only put pedicular screws, and we see a lot of complications after 1 or 2 years mainly.
Well, no, you mentioned something very important. You said that literally what they do, they put screws in the back, but they don't take the bad disc out. They don't put a spacer inside of the disc base.
Yeah.
You said you see complication from that. Let's start just with that. Why is it important to put a interbody graft or cage or spacer inside of the vertebral body? Why do you think, all of you, let's go through all of you. Farzinjan, why do you think that's important?
Yeah, I think because if you look at the biomechanics of the spine, you see like a 3-column spine, and the anterior column is not addressed when you don't put a interbody fusion. Actually, I know that pedicular screws go to anterior to the body, but still the discus space is left behind, and usually that space doesn't fuse. But in the patients we don't put in the patients that they don't put interbody fusion, usually the fusion happens at the facets, not the anterior parts of the spine. So that's one of the main reasons that many surgeons do interbody fusion is for better fusion, and some other complications are like the disc. Even some of them when they remove the diseased disc, they don't put anything there, and that messes with the biomechanics there, I think. And usually they see the patients after 1 to 5 years, the discus space is narrowed, and that causes like many adult spinal deformities we face here.
So, Dr. Attari, what you observe in your place in Pakistan, do you guys usually put an interbody graft? If not, to what percentages? And what do you think was the advantage of putting or not putting? Because there's an advantage of not putting interbody graft. The surgery becomes shorter.
Yes.
You don't have to deal with
yes. In Pakistan, we usually put interbody fusion. We are doing at our centers, but in some rural centers which are not state-of-the-art centers, they are just doing fixation and not doing the fusion. And what I think is the problem with the fixation and not doing the fusion, it is the adjacent segment syndrome. Not only the disease, it's the syndrome like adjacent segments have been eroded and other deformities have been seen with only fixation when you don't do the fusion.
So, and you're absolutely right on, both of you. Now, 80% of the weight or human biomechanical weight goes through the anterior segment where the disc is, and 20% goes through the posterior where the facets are. practically by putting an interbody graft, you are putting as well, creating a more stable construct in the front where the weight is passing through, and relying on posterior element alone. Certainly it has higher rate of failure, because then all of a sudden you're relying only on posterior element to carry entire weight. And there is something that we call macro motion, and that was something that you guys don't see anymore. Because believe it or not, when I was in residency, interbody graft was a rare thing. We only would do posterior instrumentation because that alone would take us a long time. The technology wasn't mature enough. And there's lots of cases that I would put I would do 5-level fusion. I would put only 2 cages and the instrument the rest just posteriorly, because if I was going to put a cage in every level, the surgery would be too long, too bloody, because all of you that you have done TLIF, you lose most of the blood when you're working on the facet, on the epidural veins, trying to open up the disc base. That is where you lose most of the blood. Now imagine you want to do it 5 times. You want to do a 5-level interbody fusion, and you can imagine. So there is an advantage. So doing posterolateral fusion is still one option. So never.
That's exactly how we still do it here. 5-level
Yeah.
fusions with just 2 levels of interbody fusions, TLIF or PLIF.
And that has its legitimacy, okay? But if you can, and if you don't lose half a liter blood per level for interbody work, that there is a legitimacy of better biomechanical, construct to do interbody graft. Now, let's talk about. We wanted to talk actually more about the indication for OLLIF. Now, let's talk about all the indication for fusion. And then we can talk about which of them are more applicable to OLLIF and which of them are not. Dr. Gilmartin, throw us few of the indication for fusion as general. You're muted. Dr. Gilmartin, you're muted.
I was doing such a beautiful story. So as with every the OLLIF is corridor to the spine, but advanced degenerative disc disease is the major indication to this for spine fusion. I'm saying spine fusion.
Stenosis. Let's just list them
stenosis.
Stenosis. What else?
So lumbar stenosis, degenerative disc disease, unstable spondylolisthesis.
Okay.
Instability.
Stenosis, degenerative disc disease, spondylolisthesis, instability. What else?
And to an extent, deformity like scoliosis, but then in the advanced hand, recurrent disc herniation is also another indication for
we have 6. We have
towards
6 so far. So
yes, how many do you want?
Well, it's enough. Good start. So stenosis, spondylolisthesis, degenerative disc disease. By the way, lots of people dispute that degenerative disc disease is an indication for fusion. I don't, but lots of people do. So we keep it in the list, but stenosis, degenerative disc disease, spondylolisthesis, instability, recurrent herniation, and deformity. 6. Dr. Farhar, you want to tell us, number one, why a fusion would work with stenosis? Why would we even do fusion for stenosis? Because by definition, stenosis is a narrowing of that. You can just open it up, do it like a decompression, and you don't even need the fusion. In what situation do you think fusion is necessary for stenosis treatment?
It is actually for the proper spine spacing. It means it reduce the abnormal vertebral motion, reduce the nerve compression, and that's how it reduces the pain. And actually by fusion, we are confirming the restoration of the proper spine spacing.
Yeah, that is so-called indirect decompression. Certainly, indirect decompression, what we call physiologic decompression, you can overcome it by literally put a spacer in, restore the height of the disc. Stenosis, by its name, by nature, is the narrowing of the spinal canal, neuroforamen, or lateral recess. Now, if you don't mind, Dr. Atari, in your practice, what you've seen, in what percentage of the stenosis, when the stenosis is the main pathology in Pakistan, do you do fusion versus decompression? What do you think?
In our practice and our center, we usually do direct decompression in stenosis, where the canal stenosis is severe. If it is minor in stenosis, like nerve root tension signs are minimum, then we will do indirect decompression, and for that we do infusions or ALIFs, like that.
So we talked about that the stenosis is the narrowing of one of these three structures, spinal canal, lateral recessus, foramen. Now, imagine you have all three of them. Now, Dr. Feuerbach, based on your anatomical knowledge, what is the proper way, or let's talk about first direct decompression. What is the way you overcome all of these three? Spinal canal, lateral recess, and foramen. How do you decompress that? What is the name of the procedure you do for that?
Yes, we do open laminectomy and medial facetectomy.
Excellent. You just mentioned that. By doing laminectomy, you improve the foraminal stenosis. By doing medial facetectomy, what you do, you practically remove the lateral recess stenosis, and I'm sure then you would put your Kerrison in the foramen and you take some bites of the flavum and the articulating surface to open up as well the foramen, and then you pass the probe in, you make sure the hole is open, and so on and so forth, and then you have achieved all three of that. Now, how much of the facet can you safely remove?
I think 1/3.
Well, some people say 1/3, some people say half on each side or half on one side. Generally, if you touch the disc and remove more than one of the facet, half of one of the facet, for all practical purpose, you have rendered that space, that segment unstable. You and I, we have all of us, we have worked on those facets, right? You think you are removing the half of the facet, and all of a sudden, the entire facet just come in your rongeur comes out.
Yeah.
Has it ever happened to you? Has happened to me?
Yeah, it comes in just one piece with one bite. All of it comes in one piece.
Then you have done a full facetectomy.
Yeah,
So
exactly.
the question was, in what situation, when you do decompression, do you need to do fusion? Well, if the amount of the decompression you need to have for proper decompression include that you have to remove more than half of the facet, then you are rendering that segment unstable. Then you do need to do a fusion. That is why for spinal stenosis, you need to do fusion. And obviously, what you're doing here, you're literally cutting the bone out. And once you remove enough bone away, you're opening up the space. But that as well, the same thing renders that segment unstable. Then you have to fuse it. Now, let's talk about that is direct decompression. What is a so-called indirect decompression? I mean, we have Dr. Arthur Allor here. Dr. Allor, if you like, if you can, comment what the indirect decompression is and how it can overcome the problem of the stenosis? That might be not a good connection, so don't feel bad if you're not. I just go to the next person. Now, in the indirect decompression, what we are doing we are literally restoring the height of the disc to the time patient did not have stenosis, meaning that obviously patient was not born with stenosis. Here, please, if you are able to see my screen here, we are seeing here one of these so-called indirect decompression, which we call physiologic decompression. And I'm going to move forward. Pay attention to the L4-5. What you see in L4-5 is that this is after a spacer is placed. And I'm going around the contour of the foramen. And this is before. Or I'm not sure if it comes in your screen, comes it out that the size of the foramen and so lateral recess is significantly different between these two pictures. Does it come out?
Yes,
Yeah.
yes, we are seeing it, and it is very beautiful to understand.
Well, and the idea is here, and we have done those measurements. By the time you add 2.5 to 3 millimeter to the interdiscal space, you're adding the same amount to the interpedicular space. And the mathematics of it, it works the way because it's a R squared, right? The area. That if you add 2.5 millimeter to interpedicular space, you're doubling the area space of the foramen and lateral recess. And that, as a matter of fact, opens up this space to a point that all clinical radiculopathy, almost all is gone. As a matter of fact, that is one of the points that I was so surprised. Because when I start doing so-called indirect decompression, which we call now radiologic decompression, physiologic decompression, I would oversize it. By oversizing it, I mean, I would put cages like 13, 14, 15. When I was doing TLIF, I was putting cages 7, 8, 9, 10. And now when I went to OLLIF, I was putting cages, humongous size of cages. And it took me 200 to 300 cases to understand. I don't have to. Now most of my cages are now 10, 11, 12. And that is enough in a collapsed disc, go from this to this and provide what we call so-called physiologic decompression. Now, let's start with this diagnosis of the stenosis. I can tell you based on my experience, who is a good candidate for OLLIF versus not OLLIF. Now, if you have soft tissue stenosis, in 95 to 98% of the cases, so-called physiologic or indirect decompression is enough, so OLLIF is a good case for you. What does it entail? You always have to get a CAT scan to rule out that you don't have osteogenic stenosis. Because if you have true osteogenic stenosis, true facetogenic stenosis, and practically that piece of bone you're not going to remove with the indirect decompression, then OLLIF or transcamin OLLIF would become not the best option. So in this case, obviously I have a CAT scan, I know it's all soft tissue, and literally this patient woke up and the leg pain was gone. And one of the hallmark of what I have seen in the last 14 years is that you perform the surgery, patient wake up, they have back pain obviously from surgery, but the leg pain is gone, claudication is gone. So it's very effective of the indirect or physiologic decompression is very effective to remove non-osteogenic, not facetogenic stenosis. Another factor that is of extreme importance here, if you are going to use the indirect decompression or transcamin OLLIF for stenosis treatment, is that you ask the patient, when you sit down or when you lay down, does the pain go away? If literally they say, I have no pain when I'm sitting down, I have no pain when I'm laying down, what is the difference in the anatomy when they're laying down versus when they're walking or standing up? Is that there's more pressure on the disc is more collapsed, and that reduces the size of the lateral recess foramen and spinal canal, and that gives people symptoms. Now, if they lay down and the symptoms are gone, in my opinion, that's the best indicator that indirect decompression will work. So, talking about the indication for spinal stenosis and so-called indirect decompression with OLLIF, stenosis that is not discogenic, facetogenic as well could be a part, it could be a relative contraindication, but definitely if the patient by sitting down and laying down has no symptoms, those are really good candidate for fusion. Now, the advantage here is that you do not have to cut the bone. You do not have to cut the facet. You do not have to literally deal with the in the epidural vein that causes lots of bleeding. And this result has been tremendous. So, do you guys have any question regarding the stenosis limitation and so on before we move on to the next diagnosis, which is a degenerative disc disease and axial
I
pain?
had a question when I was reading again your landmark paper. So let's say the patient does indicate for an OLLIF procedure to jack up and also promote the healing, but at the same time there is a central stenosis, like a very hypertrophic ligamentum flavum. You suggested to go staged, doing a minimal invasive, like micro laminotomy or laminectomy. Do you still recommend that, or is a second stage the same day? What do you suggest if needs central decompress?
Let's come back to the first thing. Patient comes, patient lays down, pain goes away. Sit down, the pain goes away. There is no osteogenic stenosis. It's all soft tissue that pushes on. And then I decide to do OLLIF, because if patient lays down, has pain, still pain, and there's a osteogenic stenosis, I don't do OLLIF. I go first. I do literally a direct decompression, laminotomy, not laminectomy. If you don't know what the difference is, ask, and I'm happy to explain it. But I go and do a direct decompression, remove the stenosis, and most of the time, the claudication and radiculopathy goes away. I watch the patient for 3 months. If patients still have axial pain, most of the time radiculopathy goes away. Sometimes not, because sometimes disc reherniates or something else happens and the radiculopathy comes back. But most of the time, radiculopathy, claudication goes away, axial pain stays. Now I have done already direct decompression. Then I go do a OLLIF, transcamean OLLIF. Now, let's say though, patient is a good candidate and I go and do a OLLIF. Based on your information that so far you have, Dr. Gilmartin, do you know what is the rate that after the OLLIF that I wasn't expecting to go and do a direct decompression, how often I had to go and do that? That number is 13. So
I haven't the past 5-6 months that I have been observing, I haven't seen you do any of them. So if you say 13 months.
Yeah, so see, in the since last 12 years, as of today, I have done 1,709 OLLIFs in 13 cases that I wasn't expecting to go back to do direct decompression. After the surgery, I had to go back and do a direct decompression. In 2 of the cases, there was a cage migration. In 5 of the cases, it was a trauma involvement. But then as well, the handful of cases that truly the indirect decompression wasn't enough. That is an extremely low number.
So I have a question too. In these cases that you had to go and do direct decompressions, what when you look back, what were the indicators that transcamean OLLIF would fail?
Okay, now can you ask your question one more time, please?
Yeah, okay. In these cases that you said you had to go back and do a direct decompression after a transcamean OLLIF, when you look back, was there any indicators that this indirect decompression would fail, or you missed those signs, or was there anything?
Your question is, did I figure out where did I fail? Why did I think OLLIF is enough and it wasn't enough? Now,
I wouldn't say failing. I do apologize.
No, it's failing. No, let's call a spade spade.
No, it's not.
Indirect decompression failed. you need a direct decompression. Let me
I
tell
thought
you.
that Dr. Fahrenbach meant that is there any radiological indicator or a factor that you could beforehand see, like my OLLIF
I
needs?
understood that. I did understand that, but let's call it a spade a spade. In 13 cases where I thought indirect decompression is enough, it failed. It wasn't enough. I failed to overcome the symptoms of the stenosis. And then my answer to that is that, number one, there are lots of patients that I knew I'm going to fail, like osteogenic stenosis, instability, the facetogenic, and so on. I did a direct decompression. I planned for it. These are the one that I wasn't expecting, and I still failed. And two of them, the cage migrated. Two doesn't make statistic. So I cannot answer to you the exact reason, but two of them, both of them elderly with softer bone, but that is not enough to make a statistic. Now, five of them, they had a trauma like fall, a motor vehicle accident, lifting accident involving that, and those certainly can be contributing factor. In that, the rest of them from 13, we talked about 7 already. In a handful of the people, the number 5, it's not good enough to make a statistic, come up with a comprehensive solution. Understanding. But I can tell you individually what they had, but it doesn't make statistic because that number is low. Now, this is 13 in 1,709 cases. So the number is not high enough for me to be able to answer that question. But trauma seems to be the predominant because 5 of them involved some trauma. Okay? But trauma is not something you can anticipate before the surgery. Now, there were lots of patients that they didn't go that route. They didn't go OLLIF and then open. They went first to decompression and then to literally later on to OLLIF procedure. There were a group of people as well, and I will talk about it when we talk about spondylolisthesis, because that seems to be specific to spondylolisthesis.
I want to ask a question.
Yes, please.
It's Dr. Natik. I want to ask a question.
Please,
We do direct decompression, then why we have to go again for indirect decompression?
So, though in those cases that I thought I'd do it like a laminotomy, macrodiscectomy, foraminotomy, I do a direct decompression, I don't go automatically for indirect decompression and OLLIF. In those cases, I wait. I wait for 3 months, and in 80 to 85% of the cases, radiculopathy and claudication goes away. But in some of them, in about, as a matter of fact, more than half, 55% or more, the axial pain is still there. And that takes us to the second indication for fusion, which is degenerative disc disease. Let's talk about degenerative disc disease. This is actually the question right time, because that helps us to transition to second indication for any kind of fusion, which is degenerative disc disease. In academic places in the United States, most of surgeons do not believe and do not perform fusion for degenerative disc disease alone. In the private practice, probably 80% do perform that.
Dr. Abbas, meanwhile, can I ask you a question? Can you hear me? Neda?
Yes, I can, but I think he just stepped. We're not in the same building.
Apologize.
Oh, no worries.
I would like to ask you, each of you, in your place of practice, we start with Dr. Saker Raj.
Yes, Professor. Yes.
So tell me, if, in your place,
yes.
Is fusion performed for degenerative disc disease? If yes, to what percentages, and what's your opinion on that? Let's go, all of us talk about that, because I really want to know that from all of you.
Yes. So, Professor, I currently work in Sydney. I work in public sector as well as private sector. Depending on the degenerative disc and the pathology, as well as the symptoms, if there is axial back pain, uh, and young patients varying from like 30s to 40s, and young, physiologically young and athletic. In Sydney, they perform something lumbar disc replacement and try to prevent the fusion in young patients. If patient is elderly and old and osteoporotic, first they perform, if it's alpha S1 for degenerative disc, they perform ALIF, and if there are higher levels, then they do ATP. That is very common here, anterior to psoas, or we call OLLIF, at 4, 5, and higher levels until lumbar. And a week later, depending on the persistence, inclusion of radicular symptoms or not, they do posterior decompression and posterior fusion. That's what they do in Sydney, Professor.
So let's first define what we mean by degenerative disc disease, because as we talked about, stenosis is narrowing of the spinal canal. Dr. Gilmartin, can you define for us degenerative disc disease? Can you define it for us?
I believe that's the first step of wear and tear in the spine. It starts at the disc level with the disc losing its mechanical properties and the support properties, and consequently after that, the whole stenosis will take place. So the disc disease itself is when the nucleus pulposus is migrating outside the disc space because of the surrounding, like the tire analogy that you made, is not competent enough, and the disc starts to collapse with narrowing of the disc space, with foraminal and facet joints that are starting to show signs of degeneration,
So
leading to stenosis.
okay, so yeah, pretty good definition. Dr. Farbach, is it possible that you have spinal degenerative disc disease with no other, pathology, like literally no stenosis and not much of a listhesis? Literally,
Yes, it's possible.
absolutely,
Yeah, it's possible.
yes,
Yeah,
absolutely
we've seen it.
possible.
All of us have seen it.
Okay, now the question,
Actually-
Raj, if I may ask you,
Yes, sir.
if you have degenerative disc disease
Mm-hmm.
alone, does it explain axial pain? No, no stenosis, no foraminal stenosis, no lateral recess stenosis, no claudication, no spinal canal stenosis. You have only degenerative disc disease. Does that alone explain axial back pain?
Yes, definitely. The axial pain is associated with the degenerative disc disease, and that's the most common symptom associated with degenerative disc disease.
And I agree completely with you. But in the United States, in lots of academic places, they literally say they don't believe in axial pain just based on degenerative diseases. Dr. Atari, in your place of practice, and it's a patient like this, look at the foramen. Now it is a little narrow, but not much really. It's not super narrow. Look at that. And
Yes.
do you believe, or do you practice, do you treat the degenerative disc disease by itself, which by definition is that the disc consistency is lost? You don't have
Yes.
the layering of the disc, you don't have the separation of the disc. How is your practice in that regard?
In Pakistan, in our academic sessions, we used to tolerate that when disc become dehydrated and the annular fibers got due to pressure, wear and tear appears, and then it called that degenerative. It is going to be a degenerative disc. First, it is the definition for us, and multiple things will be added on it, like other things like osteoporosis, like this process, which and plate erosions and other things. So in
Yeah.
Pakistan, in our center, which is the one of the biggest in Asia, we used to treat degenerative disc spine, and we believe in that axial pain could be due to degenerative disc, and we treat it just only degenerative disc. We treat it with any spacer or draft or fusion.
And you know, I can just tell you, you're way ahead of us in most of us in the United States, and because you're absolutely right. I do believe in the United States there is these two camps. Some believe treat it, some don't believe don't treat it, and you seem that you're more on my side in Pakistan. Dr. Farha, I just know in Germany, and I have talked to lots of surgeons.
Yes.
Most of them, they treat the spondylolisthesis and other treatment, but I have talked to very few people in Germany who treat degenerative disc disease with fusion. Am I correct, or do you have an update for us?
Yes, exactly. It is still now in the practice.
So you see, in Germany, most of the surgeons are like our academic in the United States. They don't believe and they don't treat degenerative disc disease for fusion. Now, I can tell you, OLLIF is perfect for treating degenerative disc disease, and I will come back to that. But before we do that, I see my good friend Dr. Nader is here. Dr. Nader, if you can, tell us about your experience. You have been in both academic and non-academic. What is your take on fusion for purely degenerative disc disease? Hey, Remy, nice to see you. You're muted. Oh, Dr. Nader is muted and he's had some technical difficulty. We'll come back to you. So Dr. Arthur Allor, tell us about your location of practice and your take on, or your location of practice about practice of fusion for degenerative disc disease. What do you think? More technical difficulty. Remy, if you can, tell us about your practice of fusion for degenerative disc disease. Okay, now we have still two other people. TS, I just see TS. And then Dr. Kosar. Either of you, can you tell us about your practice of fusion for degenerative disc disease?
Sorry, I'm here. If you can hear me.
Yes, we do hear you.
Yeah.
Sorry guys, just came back on.
Okay, Rami, you start. Degenerative disc disease, fusion or no fusion? You have been on both worlds, academic, private. Tell us your take.
My take is that a lot of these conditions in the US are unfortunately insurance company driven. And a lot of surgeons, in my experience, whether in academia or in private practice, do believe in treatment of degenerative disc disease by fusion. And in fact, if you remember, Hamid, some of our faculty when we trained at University of Texas believed in that as well. But unfortunately, because of the insurance companies' restrictions, if you will, we're unable to do these fusions as much as we would like to in areas of isolated degenerative disc disease, without an underlying either instability or stenosis or other type of pathology. Now, that being said, I do favor fusion myself. And I have done it in the past. Of course, when insurance is not involved, when we have either third-party payers or what have you, and it's feasible, then I will favor that option to my patients that are, that strictly have degenerative disease.
And I agree with you, Remy. I know that the insurance plays a big role in our decision-making process, and I'm completely on your side that, and I will come back to that. Second indication for transcambing OLLIF is degenerative disc disease, and it works beautifully for that, and I come back to that. But I still want to hear from Dr. Kosar about your practice of fusion for degenerative disc disease. Do you believe in it? Don't you believe in it? And in your location of practice, please. I mean, we are not going to be offended if you say you don't believe in it. That's why we are talking. We want to learn from each other. Do you perform that for degenerative disc disease fusion?
Yes, yes, I do. Actually, I work in Edinburgh,
Okay.
in Scotland. So our practice is a bit towards non-fusion side, but I do like we do posterolateral fixation in spondies, but when it is like the foramen is very narrow and the disc space is very narrowed, then we go for fusion, like interbody fusion, and we mainly do a T-leaf and P-leaf. Sometimes we do X-leaf, but we actually I have not done A-leaf in after being a consultant here in Edinburgh.
Excellent. Well, let me tell you why I do believe, and I have good amount of evidence that transcamin OLLIF is a good procedure if patient has degenerative disc disease. And I'm talking about even patient who axial pain is their only reason for pain. Now, we have to talk about number one. This is not a joke. This is not a trick question. Do you believe that degenerative disc disease can cause axial pain? Yes or no?
It can.
Yes, I think it's yes. But not everybody's answered that yes. You
I
talk.
know, but I believe that it can be yes.
Yes. Now, see, my answer to that is a very sound yes. Raj, I'm sure you know, if you're in academic, you will see some very high level, spine surgeon who don't believe that the axial pain, that degenerative disc disease by itself can cause axial pain. Now, I believe there are three mechanisms of the degenerative disc disease produce axial pain. Number one, you remember we talked about that 80% of the weight is in the front part, 20% is on the back part. So what happens if the front part is not doing its job? Then the back part has to carry more weight. There's good amount of evidence, papers. When that happens and that number goes from 20% to even 35%, it stretches the capsule of the facet in the back. And we all understand facet and the capsule of any joint is extremely sensitive. This is a known fact. This is number one. Number two, just the fact of degenerative disc disease and literally bone hitting the bone cause constantly inflammation. If you doubt that, just look at some of the CAT scan and you see, or MRI, where you see the edges of the bone are getting thicker. In the T2, I'm trying to find one. In the T2, you see that there is higher hyperintensity at the border of the bone where the bone disc is gone. You see hyperintensity, meaning there's inflammation there. And all of that, I'm trying to find one here in the MRI, but now here, I guess you see that the edge of the bone here, you see it's a little whiter. We know the inflammation leads to its own cascade of neuromodulatory kind of cascade that cause pain. That's what pain is. And then the third, this is more hypothesis, the so-called vertebrobasilar nerve, like a nerve that is inside of the bone, and some people try to burn it. So I very strongly believe that degenerative disc disease does cause axial pain, and this is based on unphysiological force on the disc, on the facet, and if you restore that pain goes away. And I have 1,700 cases that statistically have proven to us that improvement in axial pain does happen. As a matter of fact, Dr. Gilmartin is now working on our 1,000 patient, because we have obviously more than 1,000 patients, but we want to have 1,000 patients with follow-up. We are running that study. Dr. Gilmartin, when are you expecting for us to be able to publish that paper? Just the very gross timeline. What do you think?
Dr. Abbasi, you're putting me on the spot. We have actually now acquired 2 more medical students that are going to help us with this giant of a work of 1,000 patients. If you want to put a deadline on it, I hope we can do it within a year for sure. But already
about a year.
we have seen with the 300 first patients that there is a significant decrease of ODI after 1 year follow-up already.
So here we are going to now obviously we have enough patients. Hopefully in about a year we can so the median number of the when medical studies are published, the median number of the patients in those studies are 25 to 30. We published already 300 patient paper, and we are going to publish now 1,000 patient paper and show that statistically proven that this procedure works for degenerative disc disease. Okay, so from those 6, we covered 2, stenosis and degenerative disc disease. Now let's go to the third one, spondylolisthesis. Now, spondylolisthesis is something that you have to be more careful with. You need more skills, more experience to be able to treat spondylolisthesis with OLLIF, with transcambin OLLIF. The indication for spondylolisthesis is based on your level of experience, meaning we teach the transcambin OLLIF in a process we call soft transition. Soft transition, it comes in 7 steps. The level 1 is L1 to L5, no spondylolisthesis, not 5S1, no scoliosis. Once you have done 10 to 20 cases, then we go to grade 1 spondylolisthesis and L5S1. Level 2 is literally L5S1 and grade 1 mild, very mild spondylolisthesis. Level 3 is grade 2 spondylolisthesis in non-L5S1. And level 4, where Dr. Gasco shows this tremendous data, unbelievable, like grade 3 spondylolisthesis, how he very effectively goes. And the beautiful part of that when Dr. Gasco does it is that he does a grade 3 spondylolisthesis L5S1 and send the patient home same day. So based on available data, I can tell you, you can very clearly do transcambin OLLIF for spondylolisthesis but that have to be at par with your experience, definitely not what you start with, and it does work. Now we are talking about the fourth one, instability. Now, there are 2 kinds of instability, acute instability and chronic instability. Dr. Kosar, I'm sure you treat a lot of traumas.
Yes.
Your place, correct?
Yes, lot of trauma.
And when somebody comes with acute trauma, acute instability, and with neurological deficit versus no neurological deficit, does it change anything in your algorithm, how you treat them?
Slightly, yes. So if there is no neurological deficit, and even if the canal is a bit stenosed, we do MIS. And if there is neurological deficit, then of course we go for open, do decompression, and we don't take any chance. But of course, if there is no neurological deficit, but we can see the canal is occupied with big bone fragment, we go for open decompression and fixation.
And you see, you beautifully summarized my take from last 15 years. So now, obviously, there are 2 kinds of instability, acute and chronic. And acute comes with neurological deficit or without neurological deficit. If there is an acute neurological deficit, that means something very acutely, severely pushing on neural structure. That is a contraindication to transcambin OLLIF. If there is acute neurological deficit, you have to go, whatever is pushing on that nerve, you have to take it out. You have to decompress it directly. You have to cut the bone. You have to open up. You have to take the fragment out. If there is no is acute instability, but no neurological deficit, then it's a call. It's based on what you see. Like, is it somebody that you need a corpectomy or you don't need? It's become a judgment call. The chronic instability as well comes with neurological or non-neurological deficit, but it's more amenable to indirect decompression and transcambing OLLIF. But that is a conversation just by itself, Dr. Farabash. We will have that conversation about instability and direct versus indirect decompression. That has to be a completely separate conversation because it's too long. Let's talk about, we talked about 4 of them. Now it comes to your question that you asked me in the WhatsApp, deformity.
Yeah.
So how would you correct the deformity as of now, Dr. Farabash, in your place?
Okay, so right now we're facing a lot of adult spinal deformities. What we do is that because we usually approach the patients from posterior and with open approaches, it's based on the significance of the deformity. But for very significant deformities, we sometimes do 3-column osteotomies and long segment fusions. This is the practice usually we do we reserve it for patients who have gone under surgery before and now developed deformities. But sometimes instead of doing a 1-level 3-column osteotomy, we do 2 to 3-level interbody fusions to restore the lordosis. We don't do OLLIF here, so it's usually only TILF.
So what now the question with the deformity is obviously how do you bring to realign the spine as much as possible in both sagittal and coronal plane? That is the question. And the answer to that is if there is certain number of degrees you can correct indirectly by putting a cage in, and you can put the cage in the front, in the back, correct for sagittal deformity. You can put, as a matter of fact, I did a scoliosis today, and the patient looked actually like that. And then once you put the cages in and so on, literally, then you make this look like that. By putting the cage, lifting it up, putting the cage right and left to correct that. Our paper shows you can correct 5 to 7 degree in comparison from preoperative CT to postoperative CT. You can correct the coronal deformity. Now, this paper is published, the result is out there. We can send you the link. Now,
Can I ask a question, Dr. Abbasi?
Please go ahead.
So my question, like this, coronal alignment and coronal correction is very well achieved. I agreed with putting insertion of the cage, but the lot of data, like I'm not 100% sure, but the OLLIF data or the ATP data, they say we can put big lordotic cages and achieve much better sagittal alignment as per Rosoli, as well as global spine alignment goal or T1 L1 axis goals. With transcambian approach with the bullet cages, is it possible to achieve that much amount of lordosis, like 25-30 degrees between L4-5, L5-S1?
So let's talk about that. Let me finish this coronal deformity, then we will talk about the sagittal deformity. Now,
thank you, Dr. Abbasi.
Absolutely. So now in our paper, we could show that you correct 5 to 7 degree in coronal plane, the deformity in pre-op CT to post-op CT. Now, the point of importance here is that in the CT, patient is laying down, and we know if the patient is standing up, the scoliosis get about 30% or 35% worse. So in reality, before the surgery, patient is laying down, we get a CAT scan, has scoliosis of, let's say, 30 degree, 40 degree, 50 degree. When they stand up, it's much more. But post-op, we get a CAT scan. If we have corrected, like, let's say, half of it, in reality, it's more than half, because when this patient stands up, it's still the angles are still the same. So even though our study show we can correct 5 to 7 degree, in reality, probably we can even correct more. Now, the highest level of scoliosis I have done was 62 degree of scoliosis. Okay, thoracolumbar, multi-level, and so on. But if you have truly very, very severe scoliosis, that the only way you can correct that is with osteotomy, obviously, transcameron OLLIF is not your way to go. Now, let's talk about the sagittal deformities. Now, I'm looking for, actually, for some pictures here. Now, I will find it hopefully later and show it to you. In the same way that you can put the cage in the front and back, I'm sorry, in the right and left, you can put it in front and back with a different technique that we call direct lateral, MIS, direct lateral interbody fusion, meaning that instead of going transcambine, you go transpsoas and you literally put the cage on the epiphyseal ring in the front. With that technique, we have not published the data, but we can correct in what seems right now up to 3 to 3.5 degree per level. Now, obviously, this is no way close to when you put the OLLIF cage and huge footprint and so on. So what I'm trying to tell you, remember that very first slide I showed you, in no way assume from what I'm publishing out there that this procedure is going to replace all these other procedures. If anybody who believes that I'm saying that is not listening to me. So there are cases where you truly need to correct the deformity to a certain degree that is beyond transcameron OLLIF. Then go ahead, do your osteotomy from posterior, or do OLLIF and put that huge footprint cage and so on in. Okay, so, but if a 2 to 3 degree correction is enough for you per level, then this is an option for you. Does that answer the question, Raj?
Yes, yes.
Yes,
That's
so
very beautifully
don't forget to
explained,
learn
Doctor.
all the other option, okay? This is not something that fixes all your spinal problems. But I'm hoping that be able to publish that data soon, that we can correct up to 3 degree per level lordosis. But then you have to plan it. And I really invite you to go to NIH, Abbasi, MIS, direct lateral interbody fusion, and read that paper that we published in 2017.
I just shared a paper with the group,
Excellent,
Dr.
excellent.
Abbasi.
Great
I've
job.
gone through.
Thank
It's beautifully written, Professor.
Yeah, well, that explained to you that you have to plan it accordingly. You have to take a different trajectory, but then you can put literally a large cage footprint exactly in the front, because imagine the center of the disc is the fulcrum. If you are right and left, you correct for coronal. If you are front and back, you correct for sagittal deformity. Now, so we have the deformity answered, but if there's any question, let's answer it, because we still have to talk about few other indication.
I have one more question, Dr. Abbasi. Without neuromonitoring, is it possible to do transcambient? Did you try it, or is neuromonitoring is must?
Absolutely good question. And my very good friend, Dr. Varun Agarwal in India, is doing without neuromonitoring. But his neuromonitoring is the patient being awake. He does it on awake patient. So practically, even though he doesn't use neuromonitoring, the patient being awake is his neuromonitoring. And my very good friend, Dr. Niraj Vasavada in India as well, does beautiful transcambine approaches. He calls it KLIF because he uses an endoscope. He does a true endoscopic approach where you see the nerve and you don't poke through it. Works. You keep the patient awake. If you are too close to the nerve, it works. The other option is use the neuromonitoring. Neuromonitoring has been a drag on adoption of the transcambine approaches. And in the United States, I just was reviewing the papers. In the United States, only half of the surgeon perform neuromonitoring. What is that percentage in Iran, Dr. Farabakhsh?
Okay, so it's becoming more mainstream here, but usually it's only available in Tehran, the capital. In capital, everybody uses it.
Okay.
But in other cities, no one uses it.
Okay, so half and half, I would say, maybe, right?
Yeah.
Okay.
Yeah,
what about Australia? What percentage of the cases for lumbar fusion neuromonitoring is used? Dr. Raj, how often or what percentages neuromonitoring is used in Australia?
So in Australia, all the cases, 100% cases, we use neuromonitoring.
I'm a big advocate for it. Yeah, go ahead, please.
Yes, but I have worked at various countries. This is the fifth country I'm working in. I'm originally from India. In India, as you were aware, the facilities are very short in place. So sometimes we need to go ahead without the neuromonitoring.
Yeah. Now, we have Dr. Farha in Germany. Dr. Farha in Germany, how often neuromonitoring is used?
100%.
100%, okay.
Yes, there is no case without neuromonitoring.
Okay, Dr. Kausar, you're in England or in Britain or in Scotland. How often is it neuromonitoring used there?
20-30%. Some suggest prefer neuromonitoring, but most don't. We don't use too much.
So you're probably more like United States, actually. And Dr. Alor is not with us anymore, but we have TS and Dr. Bashir in Pakistan. Do you guys have any information how often it is used in Pakistan? Okay, well, now let me give you the good news. One of the problem of neuromonitoring is not being available for transcambing OLLIF. And the reason is that machine is $50,000. Now in Inspired Spine, we are getting this machine, we are going to modify it. It doesn't do everything, but it does everything you need for transcambing OLLIF. And we are hoping to create a machine under $3,000 and teach the resident and the doctors that can perform neuromonitoring right in the room, whatever is necessary. And we are very hopeful that next time I'm going to go to India and do surgery, I will build multiple of this machine with the protocols, and we bring it as a present to my friends in India, and we give it to them. So we are hoping we can solve that problem. This used to be like a $50,000, $60,000, $100,000 machine. We are hoping to be able to provide that service under $3,000. So I'm hoping that we can solve that problem. I hope that answered your question, Raj.
Yes, Professor. This is like remarkable work. You're doing the very noble work. Very fan of your work.
Well, and I'm hoping as well, not only in India, but as well in lots of other countries, adding $500 to $800 to a case is a big deal. That is how much it costs to add to the cases. And we have to always consider the economic factors in different countries. Otherwise, you see, one of the things is what we do here in the United States. We have a new method and we add another $10,000 to the surgery and nobody really cares. And that's actually bankrupting us. What I love about India is that they know from the start they have to be price conscious. So there is I think there was one indication for the fusion that we haven't discussed yet. Dr. Gilmartin, do you remember what it was?
Could you please repeat the question again? I was actually answering Dr. Kaswar.
Okay, so there was one more indication for the fusion we wanted to talk about.
Yes. I believe we were talking about the recurrent disc herniation, like how often. We say after one reherniation or second, or how many chances do we give a patient? I do believe we can tailor to each patient what they want, but I leave this.
Yeah. Okay. Well, Raj, tell me,
yes.
Do you guys do fusion for reherniation?
Well, again, it's more of a patient-based discussion and shared opinion. If it's a reherniation 2-3 times, along with the axial back pain and disc collapse, Then in that scenarios, with in first point degeneration of disc along with the reherniation, disc collapse with modic changes grade 1 or 2, we go for fusion. But if the fragment is fresh and looks like it could be just we can re-explore and they do the discectomy. That's also the approach.
Yeah.
So depending on patient to patient, we do the procedure, Dr. Pasi.
And I think you summarized it beautifully. And I used to do at least 2 macrodiscectomy before I consider a fusion. And if there is a sequester, I still would do the decompression or macrodiscectomy as well. But Dr. Farabash, I'm sure you have done reoperation on the macrodiscectomy. You have done macrodiscectomy 1 time, maybe even 2 times. For the 3rd time, you want to go back there. I am mortified to go there for the 3rd time. Why? I mean, I have a lot of experience. I'm mortified to go for the 3rd time to do a macrodiscectomy. Why?
First of all, you don't know what the previous surgeon did sometimes, and you
I know
don't know
what
the
I
extent
did.
of bone.
I'm even scared
if
to
you're
go to
doing
my
it
own.
yourself, if you did it yourself, besides the bone work, there's like this connective tissue there that actually is adherent to the roots and the dura. So that's the problem.
There is no distinction. There is no layers. There is no anatomical landmark that you can follow. And anybody who says, oh, it is just, this is what I can tell you after being 30 years surgeon. Anybody who says it is just a macrodiscectomy, he doesn't understand spine. Macrodiscectomy is one of the most complex. I'm still, after 30 years, I'm still learning. Okay?
Sometimes it's even harder than a spinal tumor that is accessible.
Yes. Macrodiscectomy, you have to consider so many things, so many factors. And if you go there for a 3rd time and everything is just a baked scar, you have no layers, you have no anatomical landmark, I'm not going there for the 3rd time for sure. I used to do 2 macrodiscectomy because my fusion used to be so massive, so risky. But now that I can do literally today, I did a 3-level fusion and it took us 1 hour and patient will be discharged either tonight or tomorrow. Because we have reduced the risk associated with fusion, if the situation right, if I'm even willing to go for the 2nd reherniation, I'm willing to consider fusion if the situation is accordingly. But right, you are absolutely right. If 2nd time is just a sequester, I'm still going to do macrodiscectomy. So it is a good option. You have to consider patient-specific situation. What I can tell you, following. If the leg pain and radiculopathy is the main symptoms, I do everything I can to do decompression without fusion. If the axial pain is the main symptoms, decompression alone usually is not enough in my patient population to address their symptoms. So fusion becomes an option. So if patient has reherniation and it's still only leg pain, I do whatever I can do, maybe a different path, maybe endoscopic, maybe go from the even other side to try to take the sequester out. But patient has reherniation, yes, patient has some leg pain, but most of the pain is now axial, then I'm more liberal to do transcambin fusion, and it works beautifully.
I'm sorry. If I may ask a question as well, because it has become so going through the different schools of, there is also a school of neurosurgery and orthopedic surgeon, fusion versus non-fusion, and also saying, actually, I hear often enough, I don't operate on back pain, only leg pain. But then again, the most criticism, and please correct me if I'm wrong, I don't want to say anything that is, so from what I understand is the critique towards against fusion is mainly the avoiding adjacent segment degeneration. And I believe that is the main reason. Now, last time I was hearing these big people of, the school of version lavage and everything, like adjacent segment, they still don't have a solution for it. And I think they talk about soft tissue damage by the classical approach. So is it because we can afford to go even younger population with fusion just because we don't do the classical soft tissue damage and we avoid the typical adjacent segment disease?
Are you familiar with the word Holy Grail? Do you know what that means, Nida Jan?
Yes, that's what I'm thinking.
Yeah. Adjacent segment disease is a holy grail of spine. What can we do to reduce the chance? What does it provoke it? If you answer that question, you deserve a Nobel Prize. But we have enough data now to show, my gut feeling says, what we do, we don't like, let me show you a picture here. When you do a regular surgery, this is a patient of mine. Are you able to see this picture? This is a patient of mine that I did the L4-5 TLIF, 2 level above it, the multifidus muscle, because these muscles are multisegmental. Okay, these muscles are multisegmental. 2 level above, the multifidus muscle has turned into scar. Additionally, you do see that now you see that screws here. When you put a screw in a regular way, you literally burning the facet of the level above. So there are lots of damage we do in a regular fusion to the adjacent segment already. My gut feeling is I strongly feel that our rate of adjacent segment disease with the MIS is lower, but your 1000 level hopefully will show us. We have enough data to go and now data mining to show if that's correct or not. So I'm going to hold my tongue before I have the data. I don't want to jump into conclusion, but my feeling is that generally not only our MIS, but any MIS reduce the adjacent level disc disease and pathology to what percentages to be determined later. Now, that is one of the reasons when I put my pedicle screws, MIS, I go very lateral. Dr. Gilmartin, maybe you have seen it, and if you haven't, if you come and observe my surgeries, you will see it that I don't go straight down. I go very lateral.
I have observed you, and I know what you're talking about.
And I want to avoid the facet capsule and the facet of the level above, especially the top screw. The other levels, you're going to fuse them anyways, but especially the top part, I go very lateral to avoid by any mean I can to have to do anything to the facet of the level above, facet capsule. Obviously in MIS, we don't burn it. We don't have to visualize that, the notch of where the pedicle starts and so on. So and I'm hoping that data will show us that our rate is lower. But a big factor as well is here again, look at that. The multi-segmental way the muscles are, and that we don't disrupt the autoregulation of the entire spine. We don't disrupt the vascularization of the bone by stripping the muscle out of it. And look at that. This is my patient, a 2-level TLIF in 2012, 1-level adjacent segment OLLIF in 2014. Patient had a car accident. I had to take the patient back. And look at that. Where I did TLIF, scar. Where I did OLLIF, pristine tissue. By the way, I'm not sure if you are able to see this, a little white here. This is our decorticator, where I go with the small tiny things, decorticate the surface of the facet, and I put biologic in. And look at that. Here you see exactly the facet fusion through that little hole without any scarring in surrounding tissue. Okay, well, this has been great. We were even longer than I expected. I think we have covered lots of indication for transcamin OLLIF, when it's good, when it's not good. Dr. Farabash, I hope we answered your question for sure. And
yeah,
Rob,
sure. Thank you.
Thank you so much for joining us. And I'm looking forward for our further conversation soon.
Dr. Abbasi, just one point. We have invited you for Vertebral Views tomorrow
Yes.
from Authority TV, and we are very excited to hear from you, and thank you so much for accepting our invite. As you, most of us are aware, and you might be aware, Ortho TV is like 45,000 network of neurosurgeons and orthosurgeons across the globe. We usually hit 2,000 live views most of the shows, and everyone is very excited to learn from you and hear from you. So
Well,
tomorrow, similar time. We'll start, and I'll share I have already shared the link, but I'll share the Zoom link also, so others can ask the question also. The social media of the Author TV already shared and kind of popularize it and circulate it. If you, from your end, if you do that too, that will be really great for all the viewers.
Dr. Raj, can you please share the link also so that I can also circulate in the social media, please?
I will share in the WhatsApp group. Is that okay?
Yes, please.
Yes,
Yes,
okay.
please.
Thank you very much.
Yes.
Well, first of all, I feel honored to be on that podcast and TV. I'm looking forward to that. It's tomorrow, 2 p.m. Central US Standard Time, which correlate to 7 a.m. Australian time. For anybody who's listening, please join us. We are going to have a fantastic host, and we're going to talk about a lots of other aspect of the technique and other things associated with this. I want to thank all of you and those people who joined us even for a little bit to joining us and contributing to this. If there's any final question or comment, please ask. Otherwise, we are going to close the podcast. Please, Dr. Gilmartin.
Well, obviously you're on the path of obtaining the holy grail in the spine surgery when it comes to fusion technique. The other thing is, in the training, I feel, and I have discussed it with my co-fellows, that we are actually overwhelmed with the amount of choice of biologics and non-biologics used for fusion. And since we are doing actually the fusion, we are depending on these extras. And ever since I saw your technique, I mean, I've been trained using the BMP or the Infuse, the brand name. And then there is this I factor that I have been seeing used. So I'm kind of in a way like, what am I going to use in my own practice? And then I saw your tricalcium phosphate as the kind of as the conveyor, and then you use the bone marrow when you're putting your Jamshidi in the pedicle screw, and then that intuitively feels like this is what we want.
Yeah. Well, I would say this is just a session for itself. So please work with Amanda. Let's make a session, just talk about biologic. There are 3 categories of biologic. BMP or protein-based, mostly BMP, but some other new stuff are coming in, like I factor is halfway there. Then there is cadaveric bone and allograft. And then there is ceramics. And what we use the ceramic that are by themselves not a good biologic, but once you mix it with bone marrow, they work fantastic. But that is another podcast that you just started. We'll work with Amanda, and now we are going to have another podcast just about biologic, because again, like OLLIF is not a solution for everything. You might using some biologic that work better for.
No, not a contraindication, Dr. Abbasi. Yesterday, I was in clinic with your other colleague, Dr. Kim, and patient radiographically perfect indication for an OLLIF. But when I looked at her, and that is what in training, you have to get the experience in the operating room. And then, so the patient had what Dr. Kim said it as a abdominal apron. Her abdomen, her belly was hanging over her knees. You couldn't even see her knees. So I said, yes, Dr. Kim, this is a good indication for OLLIF. He says, are you sure? Yeah, he says, I have done thousands of these, and I'm going to hit the aorta with this abdominal truncal mass.
Yeah. Well,
so this may be another contraindication.
Yeah. Well, there's a lot we haven't covered today, but I hope it's a good start. I want to thank all of you. We are going to conclude our podcast indication for transcameron OLLIF, and thank you everybody, and have a good night. Thank you.
Thank you, everyone.
Thank you.